Hello, my name is Lisette Valenzuela, and today I'll be presenting impacts of the carceral environment on venous thromboembolism mortality, assessing and addressing the ways that incarceration drives lethal embolisms of the lungs and the deep veins. The death of ex-NFL player Stanley Wilson Jr. illustrates the importance of recognizing and addressing the intersection of incarceration and disparities in health outcomes. On February 1st, 2023, Wilson Jr. was transported by Los Angeles County Sheriff's deputies from the Twin Towers Correctional Facility, where he had been for more than 5 months, to Metropolitan State Hospital for psychiatric treatment. Approximately 37 minutes after his arrival at the hospital, he was pronounced dead. Since he had died around the time of his transportation, there was a sense of ambiguity that the Sheriff's Department and the Department of State Hospitals used to avoid accountability in his death. Wilson Sr. and Dr. Pelaine Lucas, Wilson Jr.'s parents, also received conflicting information about the location of his death. The official cause of Mr. Wilson's death is a pulmonary embolism. That was the conclusion by both the Los Angeles County Medical Examiner and a secondary autopsy. Wilson Jr.'s family filed a wrongful death lawsuit in 2023, and in this suit, they raised additional questions about what exactly caused the pulmonary embolism that caused his death. They point to injuries resulting from custodial restraints that are all too common in prisons, jails, and detention centers, spaces that I will collectively refer to as carceral. Medical literature indicates that restraints and immobilization can indeed contribute to the development of blood clots and pulmonary embolisms, the cause of his death. Additionally, I purchased a copy of Wilson Jr.'s autopsy and found that an antipsychotic medication, quetiapine, was found in his blood. This medicine has also been associated with an increased risk of pulmonary embolism. After reviewing a publication by my PI on deaths in LA County Jail from 2009 to 2018, I noticed similarly that several cases of in-jail pulmonary embolism death occurred in people who, like Wilson, were prescribed antipsychotics that increase thromboembolism risk. This led me to the following research questions that I'll explore through a case study of the Los Angeles County Jail, the largest jail system in the US and arguably the world. These questions are: do carceral environments pose unique and elevated risks for venous embolisms? And if so, do restraints and pharmaceuticals drive carceral risk for venous embolisms? Lastly, I'll explore if unique carceral embolism risks help explain the reduced lifespan of incarcerated people. I'll explore these research questions through the following structure: contextualizing what exactly makes carceral environments unique, how VTEs work, methods, my findings from reviewing the literature, and my quantitative findings before concluding. Incarceration has been found to shorten one's lifespan by 2 years for every 1 year of incarceration, but little is known about the exact driver of this excess risk of death. Researching pharmaceutical and correctional officer contributions to these deaths may help explain this heightened mortality risk. Medical negligence in corrections often refers to the lack of access to or inadequate medical care interventions. More recent literature, however, points to the fact that interventions themselves also have the potential to cause harm. This raises moral and ethical issues surrounding the use of these interventions. The documented practice of technocorrections is one example that involves the use of medications to alter behavior, mood, thoughts, and perception. This can be used as a means of controlling behavior considered undesirable and making incarcerated people more docile. Venous thromboembolism includes deep vein thrombosis, where blood clots form in the deep leg veins, and if untreated, this can lead to a pulmonary embolism. Pulmonary embolisms occur when these blood clots travel to the lungs, blocking arteries and restricting blood flow. The American Lung Association notes that pulmonary embolism is a serious condition, with 10 to 30% of individuals dying within 1 month of their diagnosis. Understanding deaths like Stanley Wilson Jr.'s involves considering a range of factors. This research project approaches this issue by examining how a combination of physical and pharmaceutical risks associated with carceral environments pose a higher risk of venous thromboembolism mortality due to a combination of physical trauma, restraint, and a high prevalence of antipsychotic prescription. During my literature review, I found a strong concordance among the positive relationship between exposures to trauma, restraint, and VTE. However, due to ambiguity in antipsychotics and VTE literature, I used the Newcastle-Ottawa scale to disentangle conflicting findings and ascertain the strength of cohort and case control studies. This scale takes into account how VTE cases were defined and validated, along with the ascertainment of antipsychotic exposure. Additionally, it takes into account the confounding variables that were controlled for in each study. Of 114 search results, the 15 most reliable studies revealed a positive yet more subtle relationship between antipsychotics and VTE. In all three literature assessments, post-surgical patient populations were excluded due to their lack of contiguity with incarcerated populations. To obtain quantitative data, I assembled a database of 507 death records via nearly a dozen public records requests to the Office of the Inspector General, California Department of Justice, LA Sheriff's Department, and the Medical Examiner. I additionally used data scraped from the Medical Examiner's Office website by another undergraduate in my lab, which had been used for a different project. For this analysis, however, the autopsy data was filtered to the appropriate years, and any in-jail deaths were excluded. VTE cases were defined using the search terms thrombo and embo, and they were then reassessed to confirm consistency with the aforementioned VTE definition. This excluded any cerebral or coronary embolisms. A 3.6% VTE incidence among the incarcerated population was identified, compared to a 1.3% incidence among the free population, an increase by more than twofold. This statistically significant difference in incidence rates indicates that the carceral environment does uniquely promote increased risk of venous thromboembolisms. This chart maps the contributions to venous thromboembolisms and premature mortality. There are three paths to increase VTE risk unique to the carceral setting. These include antipsychotic usage, physical trauma, and restraint. Physical trauma in the carceral setting could come from custodial staff or from other incarcerated people. Restraints like handcuffs and shackles may also indirectly compound risk for VTE, as restraint-related injuries can lead to trauma-induced VTE. One limitation of the study is that in California, autopsies are mandated for in-custody deaths, whereas among the free population, autopsies are required for sudden and unnatural deaths. While this likely covers all VTE deaths, some VTE deaths may not be captured. Nonetheless, this research charts the implications surrounding the carceral priority of punishment that takes precedence over health and care. This research may also be indicative of a global phenomenon, as the Russian opposition leader, Alexei Navalny, recently died of an alleged pulmonary embolism while in prison. Russian prisoners' rights activists have warned that prison authorities routinely use embolism as a catch-all term. Navalny's death may be the result of an all too common contributors to increased VTE risk, or the commonness of pulmonary embolisms behind bars may simply become a smokescreen for a more nefarious ending. I would like to thank the URFP program, Professor Shapiro, Dr. Samra, and Dr. Bhatia for making this research possible. And here are my references. Thank you.